epithelial tissues. That was part of histology section, but we've talked about it again like we did with the respiratory system. So that kind of gives you a guideline, but it will really help if you look at your schedule between now and finals week. Say this is where I'm going to do my review, and otherwise if you don't do that, it gets crowded out with everything else. Okay? Before I come back to the diagram of the sagittal view of the head here, I want to start with kind of a going back to reviewing the serous membrane. So we've covered that for each of the thoracic organs. Remember, with the lungs we just talked about, we had visceral pleura and parietal pleura. And with the heart, we had visceral and parietal pericardium. So looking at the serous membrane for the abdominal cavity, it's called the peritoneum. There are 3 P's that we looked at that first few days of class. So just a brief, this kind of component here is for free. Background embryology. The embryo starts out as a flat disc that develops the notochord and structures here. Cells migrate down to form the mesodermal tissue, which is going to give rise to connective tissue, muscle and bone, and also pushes aside cells that are here and forms cells that are going to give rise to the lining of our tract, like the respiratory tract, and so on. Eventually, we start to see some folding. And this kind of splits up. The mesoderm moves out to form both smooth muscle and skeletal muscle. And I know this is a very rapid embryonic component, but as I said, it's for free. As this moves around and fuses, we see a longitudinal tube-like embryo. That is going to contain mesodermal structures here that will develop into the kidneys and so on. But also that mesoderm will come around, it's called what we see out here. And that mesodermal structure is going to form the skeletal wall, somatic. Remember we talked about somatic referring to body wall, sensory and motor. All right, so this is the skeletal muscle. And then this inner layer right here is going to come in and fuse. And it also has muscle. And this is going to form the smooth muscle. Of a long tube, which is essentially going to be the gut. The respiratory tract grows out of that. Our organs, so the liver and the pancreas are going to go out of that. And from the mesoderm as well, we develop the serous membrane. That is what we're going to talk about next, the peritoneum. So that serous membrane lines the cavity. Up in the thoracic region, when that divides, it's going to form the parietal pleura. But in the abdominal region, it's going to form the parietal peritoneum, where it's attached to the body wall. And like the other P's, it is a serous membrane. Meaning simple squamous epithelium, attached with loose connective tissue. Okay. Now, something that is unique in the abdominal cavity is that this parietal peritoneum then has a gap before it is attached to the organ. So in the lung, we had the parietal peritoneum pleura attached to the chest wall, and then reflected off of that onto the lung tissue. And we didn't have as much of a gap. Here we have a gap before the peritoneum is attached to the organ. So this is our visceral. Peritoneum. And this double layer of peritoneum is identified as a mesentery. Remember the blood vessels we just finished with? Superior mesenteric artery and inferior mesenteric artery. They travel through mesentery between these double layers of simple squamous epithelium to get to the small intestine or to get to the descending colon, hence that term. So that's a cross-section. Let's see how that is relevant now to our whole body as a sagittal view. So this is going to be anterior. And posterior. And we'll make this a female. Here's a bladder. A uterus. And a rectum. Be the diaphragm. And using the same colors, let me put in the liver here. This would be a cross-section through the colon. And we're going to have our pancreas here. The kidneys are there, but they're going to be up higher here in the plane of the midsection. And then we'll put some loops of small intestine. Small intestine's a little over 21 feet long. We're going to cut through it several times. Now, starting on the diaphragm, I'm going to attach the parietal peritoneum. Comes down on the deep surface of the abdominal wall. Actually, I'll put a gap there. This is our belly button. It's partially draped over the bladder. Forms part of the covering of the uterus, but doesn't completely cover it. And then drapes up part of the rectum. So everything inferior to this peritoneum is considered to be in the pelvis. So we don't have a muscle that separates the pelvis from the abdominal cavity like we do diaphragm. Actually, there's a larger bare space on the liver. Now, the pancreas is considered to be retroperitoneal. It used to be intraperitoneal, but then it folded over on itself and fused to the parietal peritoneum, and that posterior part disappeared. Okay. I'll move my colon down just a little bit. Parietal peritoneum. And now we'll look at visceral peritoneum. So it's the visceral peritoneum will be attached to the liver. And then it's going to form a double layer which suspends the stomach from its lesser curvature. Remember the left gastric artery? So on that curvature of the stomach, this attaches. And that double layer of peritoneum is known as the lesser omentum. Then on the inferior aspect of the stomach, the greater curvature, we form another double layer. But this folds back on itself, so it ends up being 4 layers actually. It folds back up on itself. And there's a potential space there that typically most of it is fused together. There's a lot of adipose tissue. This helps to insulate and protect the organs. This is not the adipose tissue that we have in our skin, or the hypodermis. And so this layer, like a fatty apron, is known as the greater omentum. And it can actually be lifted up because it hangs over and covers the small intestines as you can see. Now when you lift it up, you can't see the stomach because you're seeing the inferior surface, the deep surface of that fatty apron. But you will see the transverse colon. So now our peritoneum passes around the transverse colon and then attaches to the posterior abdominal wall by another mesentery. So the mesenteries of the large intestine, another word for our large intestine is colon. And so the mesenteries of the large intestine are identified as the mesocolon. Every other segment of the large intestine is intraperitoneal. It has a visceral peritoneum. And the other component is retroperitoneal. So I'll remind you of this as we go by. Talk about each organ, but you might want to start a list of structures when we get to the abdominal cavity, of structures that are intraperitoneal and structures that are retroperitoneal. Remember, the colon is kind of like an upside down U. So the ascending colon is retroperitoneal. It's held up tight against the posterior parietal abdominal wall. And then the transverse colon is intraperitoneal. It's suspended by a mesocolon. The descending colon is retroperitoneal. And then the sigmoid colon that makes kind of a double S curvature to get to the rectum is intraperitoneal again. Okay, so that's what I mean by every other segment. So we're looking at the transverse colon here. It is intraperitoneal. And so this structure is identified as the transverse mesocolon. Then we have our almost 21 feet of small intestine, which is coiled up. And in the diagram that I pulled down to show you some of the blood vessels from the digestive tract, you can see part of the mesentery for the small intestine. But it's similar in a fashion to the sleeve of my jacket. Let's say that my arm is a segment of the small intestine. Imagine an anaconda snake, about 20 feet long. Okay, you've laid it out on a long piece of fabric, a sheet, and you bring the two edges of the fabric up and pick up that snake. All right. So where the fabric is on the snake would be the visceral peritoneum. What we'll learn is the serosa covering of the outer wall of that organ. Where the two layers come together, you're suspending the snake, that's the mesentery. And it's considered to be the mesentery of the small intestine or the mesentery proper. Now, to fit 20 feet of small intestine into the abdominal cavity, that all has to be gathered together. And therefore, that 20 feet of mesentery is ruffled. It's gathered together as well and attached at an angle. Remember how the superior mesenteric artery went at an angle over to the right? The angle to which this mesentery is attached to the posterior abdominal wall is also kind of angled to the right. You can't see that quite so much here, but Here would be the mesentery proper. It's been cut because our glutes are cut. And then where it's gathered together and attached to the posterior abdominal wall is the root of the mesentery. Now remember with fetal circulation, we talked about the umbilical vein returning to the fetal body from the placenta and passing through the umbilicus and then going up to the liver and carrying nutrient-rich blood and oxygen-rich blood up to the liver. That is a collapsed vessel that we now call the ligamentum teres. And it is in a loop of intestine, a loop of mesentery, fold of mesentery. That is identified as the falciform ligament. We'll talk about this more on Monday when we talk about the liver. In the sagittal section, the abdominal wall, this would be the parietal peritoneum at the level just above the umbilicus. And then that would be the ligamentum, the falciform ligament. And here would be our ligamentum teres. The sagittal section through this view that I've drawn right there. Okay, so that kind of takes care of the arrangements of our peritoneum, and we'll look at some of those structures in lab. I want to show you some images from Netter's atlas of these mesentery. First view is with the abdominal cavity open, and up here would be the liver. Okay, this would be the falciform ligament, the ligamentum teres here, and here's the stomach with its lower curvature, and hanging off of that we see the greater omentum, why it's called the fatty apron, because it has all this adipose tissue in it. that is providing insulation to the underlying intestines. When that is lifted up, notice that you're viewing the transverse colon here, and this would be the transverse mesocolon, extending from the transverse colon to the posterior abdominal cavity. So all of this would be transverse mesocolon. This is transverse colon and descending colon. And here's our small intestine. So the mesentery proper that I mentioned, this would be the anaconda, if you will. And the mesentery proper would be this membrane right here, attached to the posterior abdominal wall along this angle that the superior mesenteric artery is following. Here it's been cut, so you can see that ruffled appearance to get all almost 21 feet within a space of about 11 inches. So here the ascending colon and the descending colon are retroperitoneal. They're attached to the body wall, where the transverse colon has the mesocolon and the sigmoid colon has the mesocolon. In lab, the only mesocolon we're going to be able to visualize is for the transverse colon, because the sigmoid colon usually has the small intestines in place. So now, pulling the liver up, again, here would be the falciform ligament, and here would be the ligamentum teres, which is our collapsed umbilical vein. And between the lesser curvature of the stomach and the liver, we have the lesser omentum. That's a little difficult to see. There's a few places the Thin Man chart in lab has a little bit of the lesser omentum, and one of our wall charts do. But sometimes I'll put an image like this and print it out and use it on the lab tables for the lab quizzes. All right. So now we're going to look at, before we get started, the actual organs in the picture that I drew on the board. We're going to look at, well, here's the arteries. Those are listed. They're a review of what we've already covered. So you might see those tagged again. We're going to look at the histology of the digestive tract. Fortunately, when we compare it to the respiratory tract, we only have two different epithelia. For the respiratory tract, we started out with pseudostratified, then we went to non-cornified columnar, then we went to non-cornified stratified for the pharynx, part of the pharynx, and then we went to pseudostratified again, and simple columnar, simple cuboidal, and simple squamous, and we kept changing as we went through. We only have two epithelia in the digestive tract, and it depends on whether we need to protect against abrasion or whether we need increased surface area for secretion and absorption, secretion of enzymes, mucus, and absorption of food products. So in the mouth and esophagus, we have non-cornified stratified squamous, as well as the last 2 inches, the anal canal. Everything else in between is simple columnar. Okay. Would we have microvilli or cilia? Do we need to move the food along, or do we need surface area? We need surface area. So we have microvilli and goblet cells feeding the mucus. So there are, I'll diagram this on the board, but this is showing the small intestine, which is kind of our template, if you will. There are 4 layers. The inner layer that the food is in contact with, that's lined with an epithelia. Remember our term mucosal membrane? And we had variety. The pseudostratified columnar epithelium is the epithelium of the mucosal membrane. So here we have the mucosal membrane, which is epithelium plus an underlying connective tissue. We have the submucosa, which is similar to the dermis. It's a dense, irregular connective tissue where we have larger blood vessels and sometimes glands and lymphatic follicles. Then we have the smooth muscle of the gut, 2 layers, an inner circular and outer circular layer that does peristalsis. And finally, we have the outer layer, which is the serosa. It's our visceral peritoneum. Same thing. It's a simple squamous epithelium plus the loose connective tissue underlying that. So let me diagram that on the board, and then we'll start with our actual organs of the digestive tract. So this is known as the GPAT. It's abbreviation for General Plan of the Alimentary, which means digestion. And we start out with, again, from inside to outside. have the mucosa. So the mucosa is going to be epithelium of two types. Either non-cornified, stratified squamous, beginning and the end, and in between with specializations of microvilli and goblet cells. Then of course we're going to have connective tissue. So with every epithelium we have a loose, irregular connective tissue. And then starting about halfway down the esophagus, we add a layer of smooth muscle. This is known as the muscularis mucosa. And this helps to bunch up the lining into folds, all right, to increase surface area. It's not effective in peristalsis. That's what we use the muscularis externa for. But it does help to bunch up the surface area and increase surface area. And as we go through the organs, I'll talk about specializations or changes to this basic plan. Submucosa, which is going to be dense, irregular connective tissue. It may or may not have glands that reach to the surface, and it may or may not have lymphatic follicles. As well as everything else we have in dense, irregular connective tissue. Then we have the smooth muscle that helps for peristalsis. And that's known as the muscularis externa. Your lab manual just calls it muscularis, but I would like you to add the term externa to it to differentiate it from the muscularis mucosa. Again, this is smooth muscle. And our typical plan has two layers. It has an inner circular layer, in which the muscle cells are directed as a ring around the lumen of the small intestine. So when they contract, it's going to squeeze the small intestinal lumen. And then an outer longitudinal layer. Now, if this is a cross section, the outer longitudinal layer is going to be seen with the cells cut in cross section, because they're coming out at you, all right? If we have a longitudinal cut, then we see the longitudinal muscle cells longitudinally, and the cells cut in that are circular are cut in cross section. This depends on which way you view the cut. The lumen would be where the opening is. Now this allows for peristalsis, and all of you have probably demonstrated peristalsis at some time if you lost the string to a pair of sweatpants or a hoodie and it just pulled out, and so you put a safety pin on the end, hopefully close the safety pin first, and then push that into the opening for the loop seam around the pants, and pushed it up, bunched it up. That would be the function of the longitudinal muscle as you bunch that fabric up, and then you held on to it while you pulled the fabric behind it. Then you bunched it up and then hold it behind. So then the holding on to it would be the constrictor, the circular muscle. So you go through that alternately, and we move the food through the digestive tract. Okay, so that's where that muscle function is coming from. The stomach is an exception. It has a third layer. Okay? And in the large intestine, that outer longitudinal breaks down, so only 3 bands are seen. But this, again, is our basic pattern. And then finally, on the outside, we have what's called a serosa. And that's really just our visceral peritoneum. So once again, we're going to have loose, irregular connective tissue. And then the surface epithelium, or a serous membrane, is a simple squamous epithelium. So that's the basic plan of the histology and pattern. Again, we'll talk about this changes and modifications for each area. Now we've got smooth muscle here. So obviously we're not going to be using the skeletal motor neurons. We're going to be using the autonomic nervous system. So which one is going to increase activation? So if you take a drug that is a cholinergic drug, means it copies or acts like acetylcholine. That's the neurotransmitter for our parasympathetic system. Would a side effect of that be diarrhea or constipation? Sorry to be talking about that so early in the morning. So if you take a cholinergic drug, would the side effect be more likely to be increased digestive mobility, diarrhea, or decreased digestive motility, constipation? Diarrhea. Okay? So parasympathetic nervous system and it's going to be from the vagus nerve all the way through until we get to the descending colon. So esophagus through to the descending colon. The neurotransmitter is acetylcholine, and it's going to increase motility, movement. It's going to increase secretion. Anything we need to digest and move the food along. So the pancreas is going to make more enzymes and insulin. The stomach and the small intestine are going to be more active. And then in contrast, our sympathetic, I'll get to the nerves for the descending colon when we get there. Sympathetic, we don't have named nerves. Well, coming out of the spinal cord we do, but they're postganglionic neurons, just follow the blood vessels. You don't have to learn named nerves for that. They're going to do the opposite. The neurotransmitter is epinephrine from the adrenal gland, or norepinephrine from the nerves. And it's going to do the opposite. System and following the airflow through the nasal cavity. Now we're at the oral cavity. So just remind you of some of our bones. It's actually probably going to go up here a bit. We have the maxilla and palatine bones. Forming the hard palate. Or that's the roof of the mouth as well as the floor of the nasal cavity. We have the mandible and the maxilla forming the upper and lower jaws. The hyoid bone. For muscles, what would be the muscle? Yes, orbicularis oris. Okay, so this would be our upper lip. Now, the space between the lip and the gum, or the cheek and the gum, what's the muscle here? I've not drawn it in because it's outside the screen, but what's our cheek muscle? Buccinator, okay. By the way, what's the cranial nerve that innervates these muscles? Not 5. 5 would be sensory to the mouth. 7. So facial nerve, cranial nerve 7. Okay. So the gap between the lining of the mouth and the covering of the gums, this by the way is known as the gingiva. This gap is known as the vestibule. So the purpose of the buccinator muscle is to not allow food to get caught in the vestibule as you're chewing and keep it in the mouth and between the teeth. Obviously, we have the tongue, and so this muscle would be the genioglossus. And this would be the, coming off the hyoid bone, hyoglossus. And up here, coming down, styloglossus. All right, and what's the cranial nerve that innervates those muscles? 12. Hypoglossal nerve. We have 2 other nerves here, functional nerves. What is the cranial nerve that does taste sensation? So facial nerve is going to do taste for the anterior 2/3 of the tongue, and glossopharyngeal is going to do taste for the posterior third, the bitter taste. Okay, what's another nerve that's going to provide sensory innervation? It's a little hot outside to be drinking hot chocolate, but that's what I had when I got home last night. So if I burn my tongue, what nerve would I be activating? Trigeminal. So this would also be pain for the teeth. All right, so pain, touch, and temperature. All right, now you can't see it from this view, but if you were to lift the lip up, you'll see a thin membrane from the upper lip to the gingiva and from the lower lip to the gingiva, and that's known as a frenulum. All right, if somebody has an extended, thicker frenulum, then they often will have a gap in their front teeth. So if their frenulum from their tooth to the gum extends too far down, you'll see a little gap in their front teeth. There's also a lingual frenulum from the tongue to the floor of the mouth. Right? And if it extends too far forward, the tongue is not able to move freely for speech. So you start talking like this with the lip. All I'm doing is just sticking the tip of the tongue down behind my lower teeth and not allowing it to move. So that it becomes difficult to form words as clearly as I would like to say. So it's not a difficult surgery to just give a little snip to that and allow the tongue to move more freely. Okay. Also back here, if you recall from our oral pharynx, we have folds. So there is a muscle which extends from the palate down to the pharynx and from the palate to the tongue. And these folds are actually drapes of membrane over muscle. We mentioned this when we were talking about muscle, and I said we would come back to it. And so if we were to look at this from a view through the mouth, here would be our uvula and our soft palate. Here would be the tongue. And they're also known as arches. One half of an arch would be a fold, and deep to the mucous membrane of that fold would be a muscle. All right? So the arch or the fold or the muscle is identified, the more anterior one is identified as the palato or palatoglossal arch or fold or muscle. Depending on whether you're talking about two or one or the muscle underlying it. That would be this one. And then this one, going from the palate to the pharynx. Is the palatopharyngeal. Okay? So what tonsil do we find in this region? Palatine. All right, now we're ready to talk about some accessory organs. So if you accessorize, all right, you go and you buy a necklace, or you buy earrings, or a chain around the neck, that's not essential to, we might think it is, but it's not essential to, you know, presenting yourself for school, covering up your, you know, nakedness, or keeping warm, or whatever. However, when we talk about accessory organs in the digestive tract, the meaning of that is that food does not pass through that organ. All right? So the salivary glands are accessory organs. The liver and the pancreas are accessory organs. You would die without the liver and the pancreas. So they're needed, but food, they're not part of the tract. They grew out from the tract, but food is not actually passing through them. So when we talk about accessory organs for the mouth, we're talking about the teeth. We're talking about salivary glands. Okay, sometimes the tongue itself is considered to be an accessory organ for the mouth. Before I leave the tongue and talk about the teeth, on the surface of the tongue, let me move this over, we have folds of the mucous membrane that are known as papillae. They are of different shapes. Some of them have taste buds and some do not. All right? These circles that I drew in the back are identified as circumvallate papillae. Here would be the surface of the posterior tongue, and then there is a depression, and this is the papilla here. This would be a moat, and at the base of that moat, we have taste receptors. So that the solution, the chemical that you're tasting, has to be in solution to get down into that moat and actually reach the receptors. So the circumvallate papillae have taste receptors. Okay. Another form of papillae that contain receptors taste receptors are known as fungiform. And these are actually little mushroom-like caps that go above the surface. So here would be the surface, and that would be the fungiform papillae. It also has taste receptors. And these are going to be prominent. You'll see them all over, but they are most prominent where we have the facial nerve. Right, so the anterior 2/3 of the tongue, especially the lower inch kind of margin around the tongue. And then a third type is called filiform. And this is kind of needle-shaped. It's what you see on a cat when they're grooming itself. It licks you, it's got a little bit of a rough surface. Okay, so these do not have taste receptors. There's another leaf shape that we don't demonstrate, so I won't diagram that up there. The foliate, there's just not very many of them. Alrighty, now let's look at let's see what I have. Teeth. May I erase this list here? Can I go with this? We have two sets of teeth, what are called primary dentition or deciduous or childhood. And these are the ones that you lose at various ages throughout childhood and then are replaced by permanent teeth. Once the permanent tooth is lost or pulled, you're not going to grow another one back to replace them. Right? So for primary dentition, deciduous means falling out, like a deciduous tree loses its leaves. We have 5 teeth that are present on each quadrant for a total of 20. So starting in the midline, we have the central incisor. I'm not going to diagram these, you can see them in lab. And the lateral incisor. Those are the sharp cutting edge. So the song, All I Want for Christmas Are My Two Front Teeth, would be referring to the 2 central incisors. Right. Then we have the canine, also the cuspid. That's the sharper pointed tooth. My husband's really look like dog teeth. They kind of hang down a little bit lower. Not vampire, but more like dog. Okay, so this is for tearing. And then we have 2 molars. We have the first molar and the second molar. These have flat surfaces and they're for grinding. Okay, or breaking ice if you like to chew ice. So when we add these up, we have 20 total. When we move to adult dentition, all right, we add an extra 3 to each side. So you end up with a total of 32 teeth. So I'm going to add those in a different color. We still have a central incisor. A lateral incisor. A cuspid. And then we have first and second bicuspids. So you would only see those in the adult dentition. And then we have first molar again. And finally, what many of you know as the wisdom tooth is the third molar. My daughter and I don't have this. It was never pulled. We took an x-ray of our jaw. It's not there. Okay? For some people, it comes in kind of sideways and pushes on the first and second molar if there's not room in the jaw. Typically, pulling a tooth is not a difficult thing, but for the wisdom tooth that they have to go in and actually open up the bone, then to get the tooth out, then that's a little bit more painful a recovery than just pulling a tooth that's you need to get out of the way because you need braces and they're moving teeth around. All right, if we look at the actual structure of a tooth, typical tooth structure here. I'm not going to spend too much time on this because it's much more easily visible in lab. Like a wimpy little tooth. All right, so the surface of the tooth here is that I've drawn in is covered with enamel. That surface of the tooth that is covered with enamel is known as the crown and the neck. And the neck is defined as that surface covered with enamel that is covered with the gum line, okay, with the gum tissue. The rest of this region is the root. Instead of being covered with enamel, the root is covered with a more sticky substance identified as cementum. And remember, the root is anchored to the bone via a fibrous ligament. So what do we call this joint? Do you remember? Comphosis. All right, so there's an area of joint lecture that you might see on the comprehensive where it comes back to apply. The root of the tooth is open to a cavity known as the pulp cavity, and it contains connective tissue, arteries, and veins. And surrounding all of this is living tissue, known as, covered by the enamel and in the root as well, known as dentin. The cells of dentin are odontoblasts. Again, a wimpy picture, but you can see more of that in lab. Okay, before we leave the oral cavity, we have the last of the accessory organs, which are the salivary glands. And I'm going to do that, illustrate that best by just showing you an image, because it's going to be outside the drawing that I have. There are 3 salivary glands. I'll show them to you on the screen and then write them on the board as far as their basic functions. The largest by far is just in front of the ear, just posterior to the masseter, and it is identified as the parotid, para meaning next to, otid referring to otid or ear. So this is the one that's right here. It's about 2 to 3 inches inches in diameter. It provides the watery saliva. If you smell cinnamon rolls and your favorite food and your mouth starts to water, or you're chewing gum, that watery saliva is produced by the parotid gland, and it's produced by cells that look like, over here on the right, the deep, dark purple cells. That's because of the ribosomal ER and proteins. All right. Its duct crosses over the masseter and empties into your mouth just opposite your upper second molar. You can feel a little bit of a bump there, and if you massage it, you can get it to squirt out saliva sometimes. In fact, you can find on YouTube videos of people squirting saliva out several feet, like 7 or 8 feet. And that they're not spitting, they're getting their saliva. You could also do it from your sublingual glands. In fact, that's the one that they usually use for the squirting. And those are just under the tongue behind your lower incisors. That's a more thicker mucus for binding food together. So if you're chewing, powder, whatever, Bisquick or something, and you're chewing it, that's going to help to clump it together. Crackers, anything that you don't want to spray out. That would be this one here. And then the submandibular, the mucus cells look white like this. They're not goblet cells, but they have this white frothy appearance. So this slide is actually of the submandibular gland, which is mixed. Like its name, sub, S, mandibular, M. It has serous and mucus cells. And it's a J shape, so we see a little bit of the curved part of the J on the outside of the mandible, and the long part of the J just on the inside of the mandible. So it's called submandibular. Okay. The parotid gland is innervated by your glossopharyngeal nerve, sublingual, submandibular by the facial. Let me put that up on the board, and then we'll ready to move on to the esophagus. The parotid glands are the ones that you can see from somebody that, I don't know anybody that's ever gotten mumps. But when that gets infected, you see those old-fashioned pictures of a handkerchief tied around their jaw, a little bow at the top. Okay, that's the swollen parotid glands. These release a serous or watery secretion, and it primarily is important for digestive enzymes. And antimicrobials. So if you do chew your food long enough, you will start to break down some carbohydrates, a little bit of lipids. If you've never done it, it's kind of an interesting experiment to take saltine crackers and brush the salt off. Chew them for about 5 to 8 minutes, and they will start to taste sweet, because you're taking the starch and breaking it down to sucrose in your mouth. Okay, none of us really chew long enough to do that. Just to get the taste, and then we're done with it. Cranial nerve 7 does submandibular. And sublingual. Submandibular is a mixture of serous and mucus, and submandibular is primarily mucus. All right, before we leave the mouth, back to our general plan of the alimentary tract, what would be the epithelium of the mucosa of the mouth? Non-cornified, stratified squamous. What would be the equivalent of the muscularis externa? Well, obviously, we have no smooth muscle in our mouth, but our cheek muscles. So masseter, buccinator, and the muscles that form this layer. And the equivalent of the serosa, skin. So instead of a simple squamous serous layer, we would have the stratified squamous of our skin. Okay? So when we swallow, the muscle, styloglossous muscle contracts, a bolus of food is passed into the oropharynx, which is skeletal muscle, our constrictor muscles, and that takes over as a reflex contraction, And food moves from the oral pharynx, still lined with the same epithelium, into the laryngopharynx. This is the epiglottis, which all this is pulled up and the glottis covers up hopefully the trachea. And then the food moves into the esophagus. All right. The esophagus is an organ that transitions from the oral cavity structures and muscle type to the rest of the gut, epithelia and muscle type. So when we look at the esophagus, we divide it into thirds. The entire lining of the esophagus is non-cornified stratified squamous. So that would be innervated by vagus. So our epithelium of the mucosa is going to be non-cornified, stratified, squamous. About one-third of the way down, so starting at the upper, beginning at the middle third. We see a muscularis mucosa. Our submucosa is standard, dense, irregular connective tissue, but in the most distal 1 to 2 inches, we have what are known as submucosal glands. Those are in the submucosa and send a duct up to the lining, and this is mucus. It protects from splashing of the hydrochloric acid from the stomach. All right, so someone has esophageal reflux. The smooth muscle sphincter that keeps the hydrochloric acid in the stomach is relaxed, and there's a greater amount of that, and it irritates the lining. A lot of irritation can sometimes lead to esophageal cancer in response to that. But this normally gives us protection. Then we have the muscularis externa, which remember in our typical plan is smooth muscle and inner circular and an outer circular layer. In the esophagus, the upper third is still skeletal muscle. We're not aware or consciously contract it to swallow. It's a reflex triggered when the food reaches our oral pharynx. The middle third is mixed skeletal muscle and smooth muscle. And that's where we see the muscularis mucosa start as well. And then the lower third is all smooth muscle. We begin that inner circular and outer longitudinal pattern. The serosa is not a true serosa. There is no simple squamous epithelium. There's no peritoneum or pleura in the thoracic cavity. And so, for the most part, our serosa is identified as an adventitia. Remember, the outer covering of a blood vessel was known as the tunica externa or tunica adventitia, and it's just dense irregular connective tissue attaching the esophagus to the back of the trachea and to the posterior abdominal wall of the vertebral bodies as it moves down. Only the last, as it passes through the diaphragm and attaches to the stomach, only this last portion right here will actually pick up a serosa as it continues with the stomach. Okay, that's the only portion that does that. Okay, let's talk about the stomach for a little bit. Stomach is often drawn as a fat J-shaped organ. When you see it in videos, X-ray videos, where people are swallowing a radioactive milkshake, it's actually very elongated. But in our models, it typically looks like this. There is, we're just going to go through the outer structures, and we'll probably get to the mucosal coverings later. But there is a thickening, a smooth muscle here and here. These are the second and third sphincters that we see in the digestive tract. What would the first sphincter be? Exactly, the orbicularis oris. All right. A sphincter is a circular muscle that constricts or dilates a ring-like opening. So the orbicularis oris is the first one that allows food into your mouth. The second sphincter is known as the cardiac sphincter. Or if you want a really long name, your gastroesophageal or esophageal gastric, if we're going into this. So as you swallow, this relaxes and allows food to move into the stomach. Okay? Food in the stomach is not really digested much. Its primary role is the same as in the mouth. We don't do very much chemical digestion in the mouth. The mouth is primarily mechanical digestion. All right? Let's say I had a big rock and I wanted to dissolve it in hydrochloric acid. I could stick it in my bathtub, and it would take a long time for the hydrochloric acid to break down the calcium carbonate of that rock. But if I pulverized it, if I beat it with a hammer and ground it down to a powder, and then put it in the hydrochloric acid, there would be much more surface area for the acid to come in contact with, and that chemical reaction would take place much more rapidly. That's the purpose of the mouth and the stomach, all right, is to do that mechanical breakdown of breaking the food down into smaller pieces. We do have enzymes that do some chemical digestion, but primarily the role is the mechanical digestion. So in the stomach, then, while we're doing that and emulsifying the lipid, the primary chemical digestion takes place in the small intestine. We're moving from a hydrochloric acid environment, a pH of 1 to 2, to an alkaline environment, a pH of 8 to 9. And therefore, we only let in about 1 to 2 tablespoons of mixed up, it's called chyme, into the small intestine at a time. There's hormones and neural control, and so our pyloric sphincter is the gatekeeper for that movement. So it will relax and allow just 1 to 2 tablespoons of chyme into the small intestine and then close again until that has had a chance to be neutralized and the pH raised. All right, looking at the regions of the stomach, and we were to draw a dotted line across here, this area is known as the fundus. In an X-ray, it usually is black because it has air, being the highest portion. This region is known as the body. And where it starts to taper, this area is known as the pylorus. And that's where we get the term pyloric sphincter. This curvature, where a lesser omentum attaches and our right and left gastric arteries are associated, is known as the lesser curvature, hence the lesser omentum. And this curvature that the greater omentum attaches to is the greater curvature. stop there. In lab, I'll show you the 3 layers of the muscle layer, but on Monday we'll talk about the mucosal pattern, the epithelia and the muscle.